Greetings for the day, dear colleagues. My name is Dmitrii Pshennikov. I represent Ryazan State Medical University from Russia. The topic of my video presentation is the paranasal augmentation of the piriform aperture in the functional and aesthetic aspect, age-related changes in the piriform aperture, systematic review of paranasal augmentation techniques. Piriform aperture is an orifice in central part of facial skull formed by nasal bones, frontal and palatine process of the upper jaw. This aperture is important not only in functional aspect as an element of static component of the internal nasal valve, but also as a component of aesthetic facial ensemble with surrounding structures and soft tissues affecting appearance of people. There are various surgical methods for piriform aperture enlargement with piriform ridge resection, with endonasal or sublabial approaches like in cadaveric pictures. At the same time, the authors didn't pay attention to aesthetic consequences of this resection. There are some examples of piriform aperture enlargement. In this picture and work we can see endonasal approach and using of piezo surgery. In this work and pictures we can see sublabial approach with the using of cutting drill, but the aim of this works is the same, the enlargement of the piriform aperture. In the 20th century, 3D CT scans made it possible to describe facial skull aging in detail. It was found that facial skull aging occurs due to selective bone tissue resorption in periorbital regional, premarginal region of the lower jaw, suborbital medial part, and finally piriform aperture of the upper jaw. These zones reach their maximum projection at the beginning of adulthood, while aging is accompanied by a gradual loss of volume due to bone resorption. Mandelson and Wong analyzed CT data in 300 patients, newborns and adults up to 100 years old, with equal gender distribution. The most pronounced bone resorption of anterior maxillary wall occurs immediately below the infraorbital margin and within piriform aperture base. This process is the most noticeable after 60 years old. In youth, piriform aperture is located in front of anterior lacrimal crest. Selective bone resorption is followed by displacement of the deepest edge of piriform aperture posteriorly from anterior lacrimal crest. Widespread use of CT and 3D CT scans contributes to accurate understanding the aging of facial skull and selective bone resorption. Reconstruction of these areas of lost facial skull support is another method of projection enhancement facilitating soft tissue reposition. Significant loss of bone projection of maxilla contributing to deepening of piriform aperture, especially in the lower part, reduces support for alar base and upper part of nasolabial sulcus. Traditional aesthetic focus of nasolabial correction was always aimed at correction of this fold itself. At the same time, nasolabial fold can be more logically corrected through bone augmentation. At the picture we can see the famous Russian actress Natalia Andreychenko. So, bone tissue resorption is followed by displacement of appropriate ligaments, soft tissues, and skin that contributes to deep furrows and wrinkles. As a result, the most noticeable signs of facial aging corresponding to the most protruding parts of facial skull subject to bone resorption appear. Characteristics of nose aging are known and include the following key changes: nose lengthening, nose tip ptosis, posterior displacement of columella and lateral pedicle of alar cartilage. On this slide we can see my classification of surgical method of paranasal for midface augmentation. There are maxillary osteotomy, using of outer allografts and synthetic materials for implantation, for paranasal augmentation. Surgical methods of paranasal augmentation using various approaches and modern materials have been described in my video presentation. Indications and goals of surgeries sometimes differ significantly. So, I want to begin with classic Lefort 1 osteotomy, first described back in 1901. Kenke and others reported soft tissue augmentation by 97–98%. However, this method is often unnecessarily traumatic if we are not talking about more complex orthognathic surgery. John and Han compared the results of paranasal augmentation using sublabial mandibular bone autografts and deform 1 osteotomy in patients with mandibular prognathism and midface deficit. The authors obtained good results in both groups. In their opinion, bone augmentation is preferable over upper jaw ostomy due to less trauma and higher safety. Currently, there are other less aggressive options for upper jaw osteotomy and tissue augmentation in maxillofacial surgery. For example, Hernander Alfaro developed a U-shaped osteotomy for paranasal augmentation. This technique was developed to mobilize anterior-posterior part of the maxillary bone surrounding piriform foramen and fix it with screws in a new predetermined anterior position. The authors presented two clinical cases without analysis of data. Chow described own technique of sandwich osteotomy for midface augmentation. The authors mobilized a horizontal strip 1 cm wide in anterior wall of the upper jaw from the edge of piriform aperture. Further, the bone fragment is elevated medially at the edge of piriform aperture. A support from cortical bone fragment or alloplant is placed under this fragment and bone fragment fixed with screws. Degree of augmentation up to 10 mm and symmetry can be adjusted precisely due to a fragment of the interposed tissue. The authors described 8 patients with 3-year follow-up period. Despite less aggressive nature compared to Lefort 1 osteotomy, these surgeries with modified osteotomy can hardly be classified as low traumatic and easy ones. Different pieces of the cartilage is often material for midface augmentation. So Kim described intraoral implantation of solid fragments of costal cartilage, in addition to rhinoplasty in patients with insufficient projection of the upper jaw. The patient with cleft of the lip and asymmetric nose underwent unilateral paranasal augmentation. Moore described a similar technique in 12 patients. Anterior projection of nasal base improved from the side of the cleft in all patients that led to improvement of external nose symmetry. Cartilage grafts retained their volume and provided stable results throughout postoperative follow-up. All 12 patients were satisfied with the cosmetic outcomes, and 11 patients reported subjective improvement of the nasal breathing. The another option of the paranasal augmentation is diced costal cartilage. Liang and Wang submitted a retrospective study enrolled 25 patients with nasal deformity who underwent combined surgical treatment, rhinoseptoplasty and unilateral paranasal augmentation with diced costal cartilage. The cartilage remained after rhinoseptoplasty was cut into pieces and delivered to augmentation area via endonasal approach through an incision in nasal vestibule. Mean postoperative follow-up was 12 months. Augmentation effect of autologic diced costal cartilage was stable without severe complication. The authors note that the diced costal cartilage turned out to be a simple and effective technique for paranasal augmentation. This approach provided satisfactory aesthetic results, even more natural compared to augmentation with a wall cartilage costal autograft. Don retrospectively analyzed 68 patients with similar technique, but they selected primary patient and augmentation was bilateral. Currently, there are various reports on the use of porous polyethylene implants in maxillary facial surgery for augmentation of facial skull, including paranasal zone, as a component of the midface. Polyethylene porous material is biocompatible, and one can correct its shape using the blade. Porous structure allows growth of vascular fibrous tissue and ingrowth of own tissues, while crescent shape of implant is convenient for placement along the edge of the piriform aperture. At the pictures we can see schematically in the interoperation paranasal rejuvenation augmentation with standardized porous polyethylene crescent-shaped implants. This imitated the effect of facial osteotomy with midface augmentation without bite changes. Yaremchuk didn't see significant complications after implantation throughout the entire follow-up period. The authors recognize success and certain simplicity of the surgical technique for midface augmentation. Kwon and others submitted the similar work, and the contour of soft tissue was increased by 1 to 4 mm depending on localization. Soft tissue thickness in perialar region increased by 68–74%. Regarding external nose, the authors obtained the following results: slight increase in nasolabial angle and external nasal base enlargement. So the authors conclude that piriform aperture enlargement is often a useful adjunct to rhinoplasty. Yaremchuk and Vibhakar, in contrast to the previous report, didn't see any problem in external nasal base enlargement. Moreover, they emphasize visual reduction of external nasal base. Paranasal augmentation with silicone implants dates back to 1972. The Italian surgeon Caroni used stepped implants with intraoperative modeling. The authors successfully used this technique combined with rhinoplasty only for correction of acute nasolabial angle in 24 patients. There was one complication due to installation of too large implant. In the 21st century, Fonos and Yuskovich used own original bed-shaped silicone implant. The implant could be installed in paranasal region, both via intranasal and intraoral access. The authors report good aesthetic results with low complication rate, 3 extrusion and 1 implant displacement out of 45 patients. Kim et al. Followed up 93 Asian patients who underwent paranasal augmentation with custom-made silicone implants. The thickness of implant and soft tissue augmentation respectively was different. We can see the results on the slide. The authors concluded that paranasal augmentation with custom-made silicone implants is a simple, safe, and cost-effective method. The authors reported small number of complications. 2 patients required implant extraction immediately after surgery due to significant discomfort. Implant migration without extrusion was noted in 3 cases. There was transient numbness of upper lip in 9 cases. There are several publications about rarely used material for paranasal augmentation, such as merceline mesh and multifolded expanded polytetrafluoroethylene. Piriform aperture augmentation is understandable regarding aesthetic benefits. However, the above-mentioned authors usually didn't investigate this problem in the context of nasal breathing. At the same time, Capone et al. Described original technique for piriform aperture augmentation with porous polyethylene alloplant and titanium plate after previous rhinoplasty in patients with unilateral dysfunction of internal nasal valve. Personalized U-shaped implants were installed via intraoral sublabial access under periosteum along the edge of piriform aperture lateral to attachment on inferior turbinate. 8 patients with unilateral dysfunction of external nasal valve underwent this procedure. 1 year after, 6 ones noted subjective improvement of nasal breathing. The authors observed significant improvement in nose scores. Only 1 patient noted discomfort following impalpation of implantation zone. The authors didn't consider aesthetic changes, but they demonstrate treatment of persistent unilateral internal nasal valve dysfunction via piriform aperture augmentation. So, various implants and techniques for paranasal augmentation are described. Ideal material for transplantation is biologically inert, resistant to infections, non-carcinogenic, retains physical dimensions over time, economically available and can be easily removed. However, no transplantant fully meets all the criteria. Autografts have become the standard against which all of the material for implantation are compared. They demonstrated the highest stability and the best long-term results. Autologic tissue, especially costal cartilage, has inherent stability and biomechanical characteristics similar to natural tissue structure. But autologic tissue harvesting is associated with additional damage to donor area as well as the need for certain surgical experience and time cost. So many surgeons prefer alloplastic material for midface augmentation due to simplicity and less surgery time. Conclusions. Progressive paranasal bone resorption is a common consequence of face aging. Paranasal augmentation can be used for a correction of external nose, nasal obstruction, facial projection deficit. In most studies, paranasal augmentation was combined with other surgical methods to achieve cosmetic and/or functional results. Surgeons can use intraoral and intranasal accesses. It depends on the size and the flexibility of implants. Thank you for your attention. This is my mail and WhatsApp phone for your questions.